Welcome everyone to the Transatlantic Alliance webinar on the Endocrine Society and European Society of Endocrinology's joint clinical guideline on diagnosis and treatment of glucocorticoid-induced adrenal insufficiency. My name is Roma Gianchandari, and I'm the chair of the CPG of Endocrine Society, and with my co-chair, Dr. Martin Fassnacht, who is the chair of the clinical committee of ESC, are delighted to co-chair this session. The Transatlantic Alliance is a collaboration between the two societies, and we have the Transatlantic Alliance Award now in its 4th year, the webinar series, which is now in its 2nd year, and the joint guideline series, the first of which we are discussing today. This guideline is a product of the agreement between the two societies to develop evidence-based recommendations for patient care that are globally relevant, and we truly have an international audience today. The speakers today are an incredible lineup. We have Dr. Tobias Else from the US, Professor Dr. Felix Beuschlein from Switzerland, Professor Dr. Olaf Dekkers from the Netherlands, Dr. Irina Bancos from the USA, and Dr. Anand Vaidya from USA. I have some housekeeping remarks. Please do ask your questions only using the Q&A button on the taskbar of the Zoom screen. The recording of the webinar will be available at the ESC website in about 3 weeks. And if you need CME certificate, please contact the ESC events team. I will now pass this on to Dr. Fassnacht to introduce the session and the first speaker.
Yes, thanks a lot. Welcome also from my side and from the European Society of Endocrinology side. Here, just two slides to give you information about our supporting material, which is available. These different materials which you see right now on the ESA website, they are freely available. And on the next slide here, you see document of supporting material provided through the Endocrine Society website. Therefore, please use this material if you discuss with your patients and your colleagues. And with this, I would like to introduce our first speaker. It's my great honor and pleasure to introduce my friend and long-term collaborator, Felix Beuschlein. He is professor of internal medicine and endocrinology and chair of the Clinic of Endocrinology in Zurich. And Felix, the stage is yours to introduce the guidelines. Please.
Thank you very much, Martin, and hello everybody. It's really a pleasure to be part of this joint guidelines. The title has been named. It's also on me to present a little bit of a formal introduction, including the conflict of interest of the whole group. I leave this there for a second or so. Here, it is my great pleasure to also introduce not only the people who are in this call and this webinar today, but the whole group. You see here 12 experts from 6 countries, very good coverage, endocrinologists, methodologists, nurse practitioners, which really gave a 360-degree overview on the topic. This is what awaits you today. After the introduction, you see here the different lineup of the meeting. And I will do the start with very few remarks on definitions, which nevertheless are very important in this topic. And this first sentence here, or this first phrase, more or less gives already a number of information. And I just read this for you because it is a central importance. Glucocorticoid exposure should be considered as a multidimensional risk factor, including dosage, frequency, the mode of administration, the duration of therapy, the potency of the individual glucocorticoid, and last not least, the susceptibility of the individual patient, which all gives has impact on this situation. This is also the reason that when you get numbers with regards to duration or dosage, you will find ranges. This will be mentioned in a number of times during this webinar, and I give you nevertheless somewhat of a definition here. So the duration of glucocorticoid therapy to pose a risk for adrenal insufficiency has been phrased here in 3 to 4 weeks or longer, whereas the dosage of glucocorticoid therapy to pose risk for adrenal insufficiency is any dose greater than the daily hydrocortisone equivalent of 15 to 25 milligrams. Again, here the range, and this can be calculated into 4 to 6 milligram of prednisolone, 3 to 5 milligram methylprednisolone, and 2.5 to 0.5 milligram of dexamethasone. Out of this mark, this gives rise to further definitions. The physiological daily dose equivalent is then this 15 to 25 milligram hydrocortisone. This is the average of the daily cortisone production endogenously. Everything above that and longer is called, at the sake of this guideline here, a supraphysiological glucocorticoid therapy. And with regards to timing, short-term glucocorticoid therapies and anything less than 3 to 4 weeks of duration, and long-term is greater than 3 to 4 weeks with a dose of glucocorticoids greater than the physiological daily dose. This is an important part. And a second point that I would like to mention for the sake of the argument and also to make a good understanding for treating physicians, but also for patients, we have divided the tapering into a taper of glucocorticoid therapy dose initially guided by the management of the underlying disease. That's the therapeutic taper. And later, the management of glucocorticoid withdrawal or adrenal insufficiency, so in a rather physiological range, that's the endocrine taper. And with this definition, I would like to hand over to Professor Olaf Dekkers from the University of Leiden in Netherlands, as a methodologist and endocrinologist, who is going to take over for the next part. Please, Olaf.
Thank you very much, Felix, for introducing me. Before going to the actual recommendation, it's probably good to give you some background on the rules of the games of guidelines, so to speak. I know you're all in the audience quite familiar with the GRADE approach, but just give me this 10 minutes to give you a little bit of the background. So what is the GRADE approach doing? It's meant to be a transparent approach, how you come from evidence to recommendations. So you start with clinical questions that you want to address in a systematic review. Secondly, you do the systematic review after a systematic search, of course, and then you try to give categories to the quality of the evidence. So in the end, you end up with 4 categories ranging from very low to high quality. And then step 4 is that you formulate your recommendations and you give them grades. So you can say, well, this is a strong recommendation, which says we recommend, or you have a weak recommendation, and in the text this is called we suggest. So what does that actually mean, those 2 forms of recommendations? So if it's a strong recommendation, so we recommend, then we say that reasonably informed persons, whether clinicians, politicians, patients, they want their management in accordance with the recommendation. With a weaker recommendation, where we say suggest, we say that most persons would still act in accordance with the guideline, but a substantial number would not. And please keep in mind when we talk about recommendations, that's not only the evidence that is and playing a role here. And especially in this guideline, I think this is good to keep in mind that also preferences, costs, think about different tests for adrenal insufficiency, resources, maybe in your hospital the same, that you have long waiting lists for ACTH tests, and the clinical experience plays a role. We sometimes think that clinical experience should not play a role because everything there is evidence. But why then have such a team with such great clinicians with a lot of experience? So the clinical experience plays a role, and this all comes into play when you go from evidence to recommendations. So here's my first, or the first audience question, and please take into consideration here that from the adult population in England or in the US, we know that in every year, 1% of the population, or even 1 to 2%, is at some point treated with corticosteroids. So now the question to you is, if you have this in the back of your mind, what do you think the evidence for the optimal test algorithm or even tapering scheme is? Is it very low, low, moderate, or is the quality of the evidence high? And please, can we start the poll? Okay, so here are the results. 9% of the people in the audience say it's very low. Then we have 46% say it's low, moderate, reasonably large proportion, 41%, and 4 voters say the quality of the evidence is high. Well, let's go here, and this is the summary of the quality of the evidence that we have. The evidence is based on really small studies. And I said, for me as a methodologist and as an endocrinologist, this was a sort of surprise, given that so many people use glucocorticoids. Most of the evidence is descriptive and does not inform on optimal treatment, optimal tapering, or optimal testing for the diagnosis of adrenal insufficiency. And the other striking point is that most of the literature on testing does not relate biochemical results to clinical outcome. So I think this is sort of bottom line of the methodology, that we can say that the evidence for all clinical recommendations is low, and most of the times even very low. And then you might come into a question and saying, well, if you don't have good evidence, why not skip the guideline altogether and go for a consensus meeting? We decided to go for a guideline, and here's some of the reasons for doing so. The idea of guidelines is that they're based on solid evidence, and that's true, but I would say it's based on the evidence that is out there, even if it's not entirely solid. And the other point is that even if you have strong evidence, there is no automatic rule that tells you how to come from evidence to recommendations. So that means that every recommendation, even in the presence of strong evidence, requires consensus, requires taking into some consideration, for example, preferences, costs. And we think it's always important to search for evidence because it's the most transparent way to deal with uncertainty and to deal with non-solid evidence. So in the absence of strong evidence, we still think a guideline is very valuable, and we can't abstain from guidance because the evidence is not solid. So that's the reason why we think we have guidelines. And I think this quote in the GCNM, it's now 10 years old, but it's still a very valid quote in my opinion. And here it is. It's certain that high quality evidence will not be available in all clinical situations. I would say in many situations where we as endocrinologists have to deal with. And in situations where high quality evidence is not available, expert opinion and careful synthesis of low quality evidence will continue to appropriately guide clinical practice. And I hope we have done so. So what were the clinical questions that we addressed in the systematic review? There were 4, and I will address 3 of them. We were interested in the question, what is the incidence of recovery of the HPA axis in patients with glucocorticoid-induced adrenal insufficiency? We were interested in the optimal tapering scheme in patients that no longer require glucocorticoid treatment for the underlying condition, and we would like to know what the diagnostic accuracy is of a morning cortisol versus a 250 ACTH test. So there we go. This is a slide with some old data published in the GCNM now 9 years ago, and it showed that if you simply test patients who use glucocorticoids and you test them for adrenal insufficiency, that a high number of patients have biochemical evidence of adrenal insufficiency. For example, if you take the first line of the graphical picture, it tells you that if you take oral glucocorticoids, approximately 50% of the patient has biochemical evidence of adrenal insufficiency. That's old news, but we were interested in the question, what is the probability of recovery? And you can see there were some studies that retested after 4 weeks, some retested after 6 months. And you can see that the proportion of patients with biochemical evidence for adrenal insufficiency is going down from, well, here in this case, from a little bit more than 50% to 25%. So a considerable number of patients recover from adrenal insufficiency in a time period up to 6 months. What is the problem here with the evidence? The problem is that you have many different populations. You have different dosages of glucocorticoids, different duration of treatment, and then different tests were performed, different cutoffs were used, and the selection of patients was unclear. And I think another very, very important point is that the data were in no way related to clinically relevant outcomes, whether symptoms or adrenal crisis. The second question we would like to address was, what is the optimal tapering scheme? Going slowly, going fast? So we searched for the literature and we found 5 studies only. They were in multiple sclerosis, asthma, and COPD. And in all those studies, adrenal insufficiency was not a primary endpoint, but the primary endpoint was the disease activity. And what we did was look at the side effect table to see whether adrenal insufficiency or adrenal crisis occurred as a side effect of tapering. In these studies, and I think in a way that's a plus, no biochemical testing was performed. 3 studies compared to placebo, 1 study comparing tapering versus continuing, and in 1 study there was an individualized tapering algorithm. And in total, this comes down to approximately, 750 patients. In these patients, no case of severe adrenal insufficiency was mentioned. Again, this is not a very large number, given that adrenal insufficiency probably is anyway rare, but it's a sort of reassuring that, that if you taper, not many patients seem to come into problems. Again, relatively small number of patients, no biochemical testing, although that might also be a slight advantage here, and no data comparing tapering versus stopping abruptly. Then the final question for a systematic review was, what is the accuracy of a morning cortisol versus a 250 ACTH test? And here you can see on the slide there are 3 studies. And if you take a cutoff of your morning cortisol around or slightly above 300 nanomoles per liter, then this quite accurately predicts a normal ACTH test. So these data seem to suggest that you can replace the ACTH test by a simple morning cortisol measurement. So again, some remarks here. Relatively small number of patients, again, and no data on the relation with clinical symptoms or adrenal crisis. And having said that, that was a little bit on the background of the systematic review, including some results of the systematic review. I would like to hand over to Tobias Else from Ann Arbor, endocrinologist and co-chair of this guideline. And I will stop share